Hello, PsyQ community. My name is Mark Takolowski, and I am a medical science liaison from the Otsuka Pharmaceutical Development and Commercialization Incorporated Field Medical Affairs team. I'll be serving as moderator for today's exciting discussion featuring Madhukar Trivedi and Laura Melaro. Dr. Trivedi serves as the director of the Center for Depression Research and Clinical Care, Betty Jo Hay Distinguished Chair in Mental Health, and Julie K. Hirsch Chair in Depression Research and Clinical Care at UT Southwestern Medical Center in Dallas, Texas. Dr. Trivedi currently serves as a PsyQ section advisor for the Major Depressive Disorder section. Dr. Melaro was a UT-HSC College of Nursing Assistant Professor and PMH-DNP Concentration Coordinator from 2014 to 2018. He transitioned to a volunteer clinical faculty role in June 2018. Her 40-year advanced practice nurse work experience includes primary care, private, psychiatric outpatient, inpatient, and federally qualified health center settings. She is the 2018-2019 chair of the National Organization of Nurse Practitioner Faculties, PMH Special Interest Group, and president of the Tennessee chapter, American Psychiatric Nurses Association. She presently consults and provides face-to-face telehealth integrated behavioral health services at Hardeman County, Henderson, and Stanton Community Health Centers. Today's webinar is sponsored by Otsuka Pharmaceutical Development and Commercialization Incorporated and Lundbeck LLC, committed supporters of the mental health treatment community. The information provided during today's presentation is intended for your educational benefit only. No CME or CEU credits are offered. It is not intended as, nor is it a substitute for medical care or advice or professional diagnosis. Users seeking medical advice should consult with their physicians or other healthcare professionals. While conducting this discussion, our speakers aim to provide you with information that is accurate, not misleading, scientifically rigorous, and does not promote Otsuka products. So without any further ado, I'll turn the presentation over to Dr. Melaro. Dr. Melaro, the floor is yours.
Thank you. I appreciate getting to present with Dr. Trivedi and excited about our topic. When we look at the prevalence of depression, it affects approximately 8% of the American adults in a given year. It's estimated that it's going to be the leading cause of disease burden by 2030. When we look at age of onset, when considering genders, middle age is our largest prevalence gap. However, there's not much difference between the genders. Across our references, it was noted that nearly twice female gender is going to have major depression versus male. When we consider comorbidities in the studies, especially looking at Marcus et al., which looked at the STAR-D study, they found generalized anxiety, somatoform disorders, and bulimia were more prevalent with females with major depressive disorder, whereas males tended to have more obsessive compulsive symptoms and substance abuse. When we consider transgender, when we talk about prevalence, the studies have been limited mainly because earlier studies have looked at the LGBTQ community as a whole. So transgender persons were not represented as well. It's estimated in some of the newer studies that it's about 0.6% of the presenting transgender population that has major depressive disorder. But a lot of times it's people that are seeking hormonal replacement and treatment for transition, but they're trying to focus more on studies where they look at the transgender population and the mental health arena and them seeking any form of care versus just the transition and hormone replacement. When we talk about differences in symptomatology, you look at females versus males. You know, Crum and Marcus both looked at atypical presentation, and they looked at irritability, aggression, substance abuse, and risky behaviors seem to be more with males, whereas females, you found more anxiety, somatoform, the eating disorders. But when you look at atypical symptoms, it's based on the definition in those studies. So when we look at increase in appetite, fatigue, low energy, those types of symptoms, believe it or not, females are noted to have more atypical symptoms than males. When we look at a greater severity of self-reported depressive symptoms and anhedonia, this came out of some of the literature with inflammation, and it seemed to be more prevalent in the females. When you talk about some of the representations that males will give, they'll usually complain more of decreased libido. They'll have a little more psychomotor agitation versus, more leaden type symptoms by the females. You have to think about males are more apt to complete suicide, complain of insomnia, irritability. They will express more anger and aggression. That doesn't mean they have more emotions. It just means they express it more. When we look at gender-specific considerations, when you look at genetic links, there really aren't any proof that the genes in the X chromosome are more associated with depressive symptoms. There are correlations with estrogen and progesterone with depression. Bethia in 2000 looked at the estrogen phases of life, and when you considered the impact of oestrogen and progestin on serotonin, a lot of people will look at, puberty, pregnancy, perimenopausal, menopausal type of presentations with females to see, do they have depression? And it appears that most people believe that they do have major depressive symptoms during those time frames. When we look at more the interpersonal processes, women fall under that stereotype that they are more emotional than men. Theories look at women as being more empathetic and caring towards others. I think that's the role that's put forward for them. Women are more prone to mask their emotions to fit those social norms. When we look at sort of the social norm characteristics that are expected of men, Malik talked about the tough guy or the strong, give them hell guy, whereas females and identities are not, when women express anger and they express a number of these more strong emotions, which are attributed to males, it is not as well received. When Crum looked at the two subtypes, they looked at masculinity ideals and the subjective perspective. And depression was considered weakness for males. They're taught to deny being weak, and they're taught to close up. When you look at the sociological, social, and cultural factors, we look at males are usually expected to be the breadwinner, to be in control, to be successful. They're more apt, if they have a role model who models appropriate expression of emotion, and they seek help, they're more apt to seek help. But most often, they don't seek help when they have depressive symptoms. When you look at the central paradox relationship theory, it's sort of grounded that rejection or anticipation of rejection leads to anxiety and aggression, and that females are more apt to be hypervigilant to this rejection. And when we look at the impact of romantic relationships and the ability and its impact on depression, females sort of explicitly or directly learn not to express. That fear of rejection leads them not to express a lot of their emotions or thoughts, and impacts their ability to have healthy relationships. When you look at the sociological factors, women are exposed to violence and they're more prone to internalize their feelings related to that violence. There is a threat due to physical strength, or in some, not across nations, males often have more of the financial control, and females are held to comply at times or do some things because they don't have other opportunities. The stereotypical women are at home and men are in the workplace still applies across a lot of cultures. When you look at these types of factors and how women and males handle conflict in the relationship, it can be significantly associated with depression. I'm going to ask for some comments from Dr. Trivedi and how he looks at some of these multifactorial considerations and how he thinks they impact depression.
So thank you. That was a wonderful summary, and I think it highlights the two things that I was sort of come to mind. One is I think like many of the other chronic medical diseases, depression is really heterogeneous, so that both differences between men and women and within men and women also there are differences based on a lot of exciting data coming out now from genomics, proteomics, and most importantly from circuit-based studies that show that there are real distinct differences in individuals about what is really driving their depression. So therefore, men and women actually, their circuits, for example, there's now increasing data showing that emotion regulation may be driving depression symptoms in women more than in men. And similarly, there are so many other biological differences, and obviously then the whole role of stress, early life trauma that has a bigger impact on women are both really driving some of these differences. So therefore, in individual groups of patients, we have to try to get a better history so that we can match their illness and their presentation with the best treatments. And I think you've already mentioned, for example, on this slide, the whole role of hormones and how they vary between genders is actually quite remarkable. And so that was a fantastic summary that we have to be mindful that there are different presentations patients will have, but within that, women have a fairly robust difference in terms of how their symptoms are presented than men, and then therefore the treatment decisions obviously we have to make differently. There, as I was mentioning, these are really neuro and anatomic differences you can see between men and women, and some of the more exciting data coming out of Eric Nestler's lab and others, gene and protein expression or histone modification studies from animal models of depression in men and women have clearly shown significant differences in gene expression and protein expressions in men and males and females. That obviously then has the genesis of how that reflects in terms of development, especially architectural changes that happen in post-puberty in girls and boys are so different. That pruning process that happens in neurons really has a big impact, especially at that time if there is life trauma happening, then that changes neurogenesis, glial development, and there are differences in neuronal apoptosis between men and women as well as a result of all this. The synaptic connectivity that is really developing varies between men and women, and at least increasingly we are now able to identify some of these differences in functional connectivity in terms of resting connectivity or in response to tasks like emotion regulation task or reward task. We see differences between men and women. And that really will eventually help us guide best treatments that are more particular to the person's psychopathology rather than blindly doing the trial and error we do currently.